I was diagnosed with stage 4 gastric cancer back in April 2024, and I've been on ongoing treatment since then.
The symptoms that typically bring people to medical attention are not very specific. It's often fatigue, it's often feeling full. Sometimes people see a spot of blood in their stool or on the toilet paper. Sometimes people feel like they're losing weight and they don't have a good explanation. And some people have some just sort of general abdominal pain.
After a few more scans, eventually a mass in my stomach showed up, and when they took a biopsy of that mass, it came back as adenocarcinoma.
Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer.
Hey everyone, welcome to Cracking Cancer. I'm your host, Dr. Kyle Concannon. I'm a physician scientist at the University of Colorado, and today we're going to be talking about gastric cancer. And joining me for this topic is Frank Blandon and Sam Klempner. And I'll let you both go ahead and introduce yourself. We'll start with Frank.
Yeah, hi, I'm Frank Blandon. I'm originally from Nicaragua, and right now I live in the suburbs of Atlanta, Georgia. I was diagnosed with stage 4 gastric cancer back in April 2024, and I've been on ongoing treatment since then. Initially, I was misdiagnosed with testicular cancer, and I did a couple of months of treatment for that. And after getting a second opinion, I was re-diagnosed to gastric cancer, and yeah, that's pretty much it.
Geez, well, I look forward to diving more into that story. It sounds like there's a lot to unpack there. And Sam, maybe you can introduce yourself.
Yeah, I'm Sam Klempner. I'm a GI medical oncologist at Mass General Brigham in Boston, and I've been doing gastric and esophageal cancers for almost 15 years now.
All right. Well, thank you both for taking the time to join. I think you're going to have great complementary experience to add here. But first, maybe to lay the foundation of what gastric cancer is and how that might present. Frank, it sounds like you've had a kind of a complicated presentation when that first arose and there was confusion. Can you go a little bit into your diagnosis and what led to your gastric cancer diagnosis?
Yeah, so my initial symptoms were I actually had a swollen testicle, and I was having some lower back pain, which initially led me to see a urologist. The urologist sent me to do a CT scan of my back, and they noticed a bunch of enlarged lymph nodes in my back, chest area, multiple regions, and they were suspecting lymphoma. They did a biopsy of a lymph node on my back, and I got diagnosed with testicular cancer then.
And was that diagnosis in question at the time? How did that progress to be a diagnosis of gastric cancer?
It wasn't in question, but it was a local hospital that I went to that got my initial diagnosis. Then I went to a couple of other places. Initially, not because I was suspecting that it was the misdiagnosis, but because I wanted to get treatment faster, start treatment faster. At the other institution that I got a second opinion, they kind of did not trust the pathology report, so they decided to do their own pathology on a different lymph node that I also had on my neck area. It was easily accessible, and the pathology report came from there as unconclusive, as they didn't know what it was a carcinoma, but with a non-primary. So
I see.
after a few more scans, eventually a mass in my stomach showed up, and when they took a biopsy of that mass, it came back as adenocarcinoma, and then it was gastric cancer then.
I see. So it kind of sounds like their initial biopsy, the stains under the microscope weren't clearly gastric cancer. And they said, let's
Right.
put this together. There's a swollen testicle. swelling in the abdomen, lymph nodes. This looks like it could be testicular. That's our best bet. And then after a little more investigation, they were able to identify, no, this is probably more likely from the stomach. Does that sound right?
Yeah, which I didn't know at the time was that, so I think I had maybe 3 CT scans, and on the third CT scan, they noticed the mass in my stomach, which probably was there all along. But I didn't know that the stomach could be collapsed in the scan. So they said, well, it wasn't, we couldn't see it then. But by the third scan, they noticed that that mass. And, they, at that time, the suspicion came about for gastric.
Geez, I mean, that sounds like a whirlwind. That must have been such a hard couple months for you, going through all that ambiguity, extra testing. How did you navigate that?
Yeah, I think it was very difficult, especially the prognosis,
Yeah.
because I went from, at the time, I was told that I was going to do treatment for 4 months. And then when I finally got a diagnosis of gastric, then, I was told, okay, you have to get a port installed because now it's going to be like an indefinite, right, palliative care at that point.
Geez, well, I'm so sorry you went through all that, but thank you for taking the time to, use your experience to teach others. And then maybe building on that initial ambiguity, I want to pitch it to Sam. Sam, before we get into what gastric cancer really is, and I just want to kind of piggyback on Frank's story here. Is it common that the initial diagnosis of a gastric cancer can be confusing or hard to confirm, like in Frank's story?
Yeah, Frank, I think your story highlights some common themes. There's the symptoms that typically bring people to medical attention are not very specific. It's often fatigue, it's often feeling full. Sometimes people see a spot of blood in their stool or on the toilet paper. Sometimes people feel like they're losing weight and they don't have a good explanation. And some people have some just sort of general abdominal pain. And those are the typical things that might bring you to seek medical attention. So those are a very wide open book when you come to an office and say, I have fatigue or I have abdominal pain. And that usually will prompt some form of workup, some blood work and maybe some scans. For example, we sometimes see low red blood cells called anemia as a common reason. And that's probably because, as Frank was alluding to, tumor in the stomach may be slowly bleeding, even though you didn't see any blood in the stool. And that can be one of the clues that the doctor may say, or the nurse practitioner may say, hey, we need to understand why you're anemic when you're a young man or an older woman, etc. Like, we need an explanation, and that will often lead you down a track that ultimately may end in a stomach cancer diagnosis. And everyone has sort of their own story, but a lot of them share similar pieces of initially non-specific symptoms. Sometimes totally incidental diagnosis. You got in a car accident and someone did a CT scan and they saw thickening at the junction of the stomach and the esophagus. Really, we see that periodically as well.
And I think it's great to hear those are the signs, symptoms that many people experience. What is going on in the stomach? Like, what made that turn cancerous? What's happening down there?
Yeah, common question. Short answer is, for any individual person, we often don't know specifically why they got their cancer. We have some observations from thousands of people over years about what are features that tend to be associated with more stomach cancer or more esophagus cancer or more breast cancer or any cancer. And those are called risk factors. And the most common ones for stomach cancer are essentially anything that causes chronic irritation of the lining of the stomach. This could be chronic ulcers. This could be chronic gastritis from multiple causes. This could be gastritis related to an infection, a bacterial infection called H. pylori, which is super common around the world. but the end result is some form of chronic insult to the lining of the stomach, increases the chances that some lining cell is going to acquire a mutation and ultimately become a tumor. So these are tumors that generally start in sort of the cells that line the stomach.
Okay. So when those cells that line the stomach become inflamed over a long period of time, that's one way that we know about that can cause these gastric cancers.
Yes, and there are rare things that people may be born with, a gene that is associated with a high risk of stomach cancer. Classic one is something called CDH1, but there are other genes, Concannon family genes, BRCA genes, Lynch syndrome genes, etc.
Hmm. And Frank, did any of those risk factors apply in your case?
For me, I didn't have H. pylori or Lynch syndrome or any of this. The one thing that I found out later after I was diagnosed was that there was Epstein-Barr virus on the tumor itself. Come to find out that is also another cause, I guess, or risk factor maybe. And to Dr. Klempner's point, 2 years before I was diagnosed, I was anemic.
Hmm.
Um, and I got blood work done to see why I was anemic. I got put on iron supplements for about a year, and that went away. And coincidentally, maybe a month before I was diagnosed with gastric with cancer, I was anemic again.
Hmm.
So could it have been related? Likely, I'm not sure.
Sure. Yeah, Sam, and I'm curious to hear your thoughts. One, about Frank's anemia that he had, and two, about the Epstein-Barr virus associated with his gastric cancer.
Yeah. Epstein-Barr virus is the same virus that, is associated with mono, when you think you're a teenager and you got mono, same virus. It's a virus that can live within all of us for our whole lives and often not cause problems, but sometimes be associated with certain cancers, including stomach cancer and some lymphomas. It's probably in the US a small minority, single digit percentages of stomach cancer that are EBV associated. In around the world, it may be as high as 10% of cases are associated with EBV. They often have a very distinctive look under the microscope. Lots of what they call lymphocytes, which are immune cells gathered around tumor cells, will sometimes prompt the pathologist to do the EBV testing of the tumor cells because they're triggered by this pattern that they see. Pathologists are always looking for patterns. They're very good at recognizing patterns, and features of cancer, tend to make patterns. In terms of the anemia, in a young man, anyone who is anemic, it's not a normal finding, and it usually is related to you're not absorbing enough iron, you don't have enough building blocks of blood like folate or B12 or iron. It's getting destroyed too fast from some other process, or you're losing blood. And usually the loss of blood in the GI tract will trigger some form of workup. But anemia is so common, and sometimes if it's very mild, it wouldn't, if you're a young guy and you show up to a primary care office and you have a very mild anemia, the first thing that doctor or nurse practitioner, et cetera, is thinking is not going to be stomach cancer. It's going to be something else. So they will often try sort of typical measures, like what happened to you, Frank. And if it goes away completely, then you may less likely think that it was a cancer. But if it comes back again, you've got to kind of pursue the next round of workup to understand why this keeps happening. And usually that would result in some form of endoscopy for many people.
Okay. And so let's say we proceed with that and someone gets the endoscopy, they see an element of cancer in the stomach and they biopsy that. Are there any particular things that are really important these days to look for that might guide what treatment one may have?
Yeah, I mean, I think Frank probably could name the markers on his tumor. He already named one, EBV, but there are several others that are quite important. So, yes, ultimately you need a biopsy to confirm the diagnosis. The biopsy gets looked at under the microscope. It gets tested for multiple proteins, which both can help confirm the diagnosis. So sometimes these are like CK20, et cetera, CDX2. And then there are proteins that help us pick therapies and also tell us about sort of the general biology of the cancer. I'm happy to list those if you want, or whatever
Yeah,
easy.
it's interesting. At least most of my work is in lung cancer, and we still struggle with getting all patients with lung cancer biomarker testing. This is testing that can guide the kind of treatment they could get. It could make them eligible for trials. So I'm curious if any of those types of things or classes of tests are maybe equally important in gastric cancer. And if so, could you speak to what they may be?
Yeah, definitely. So there's two flavors of biomarkers. There are things that predict how you might respond to a given therapy, and then there are things that tell you about the inherent biology of the cancer, like is this aggressive or less aggressive, et cetera. And those are typically prognostic biomarkers. Predictive is the ones that patients care the most about in general, because those are the ones that help us decide the therapy that they're going to get or we're going to recommend. In gastric cancer, there is 4 biomarkers that are sort of critical to know. And any patient who has gastric cancer, particularly advanced disease, should know these things about their own cancer, and also their doctor and team should have tested them. One is called mismatch repair, or MSI or MSS status. This refers to a set of proteins and a set of genes that help repair DNA. So when these are mutated or lost, their tumor gets thousands and thousands of mutations, and this biomarker is associated with a better response and outcomes with immune therapy. Then there is a second biomarker, which is called HER2 or HER2. This is a protein that can be overexpressed in like 20% of patients, or the gene can be amplified as well as the protein being expressed. And this is also very predictive of response and benefit from drugs that target HER2, and there's several of them. Next, we have something called PDL1. This is a protein on the surface of tumor and some immune cells around the tumor, which is essentially a marker of response to some of our immune checkpoint inhibitors. So some of the same drugs we use for MSI high or microsatellite unstable. And then finally, the newest biomarker is something called Claudin 18.2, which is another protein that can be expressed at high levels in almost 40% of gastric cancers and GE junction and esophageal cancers as well. And this is also associated with benefit from drugs that target Claudin 18.2. There are many other markers that can be tested for, and other types of tests like circulating tumor DNA and sequencing of the tissue that can expand and find additional alterations in the cancer cells. But they are not as established yet, meaning they're not as linked to approved drugs.
Well, thank you for that really detailed explanation there. I think it sounds to me the condensing that is saying that the biomarkers that will determine if someone is a good candidate for immunotherapy, or if there are other things on their cell surface that can lead to different proteins being targeted. The HER2 protein is one that we're seeing a lot in a lot of different cancers, which is a great opportunity to look at that. And we have targeting things, we have that in the lung. For those who are listening to the podcast frequently, one of our common co-hosts and one of the lead founders of the podcast is Samantha Morello, who has a HER2 mutation. a little different, but many times they're treated with the same things. And then the Claudin 18.2 is also particularly interesting because this shows there's all this new research that's coming out across all these cancers, including gastric. And these are the kinds of things that I think in lung cancer and many other cancers, um, understanding their importance to make sure those are tested isn't always done up front. And this is a situation where patients can bring these kinds of questions to their oncologist, particularly if they're not used to treating a certain type of cancer as often. And it's a nice little checkbox. This happens to me sometimes when I'm in clinic, and patients will make sure we run through, and it might give the patient some reassurance. Or if there was something missed, then we got to make sure we get after that and get it done. Frank, do you have a sense of if these biomarkers were tested in your tumor?
Initially at the local hospital, they were not, but when I got the second opinion, they were tested for biomarkers, especially after it was a carcinoma non-primary, right? It was sent for sequencing to see if they could figure out what it was, and at the same time, they were checking for sort of like any biomarkers that could be used for treatment opportunities. Like, for instance, one of the big ones was the PD-L1 for to see whether I qualified for immunotherapy at the time.
And did any of those biomarkers help determine a treatment that you would ultimately be on?
Yeah, PD-L1 was the I think the biggest one, because that made me eligible for immunotherapy. They also tested for Claudin 18.2, but at the time when I got diagnosed, that drug that wasn't approved yet in the U.S. But I've been on immunotherapy since then, since 2024.
Okay, yeah, maybe this is a good time to transition to that. Can you bring us back to that first discussion with your oncologist when we collectively identified that this is actually a stomach cancer, and then how they went through what kind of treatment options to consider?
Yeah, at that time, once I got the official diagnosis of gastric cancer and I got the results for the biomarkers, then I introduced immunotherapy as the main thing, and I got first lines of chemotherapy at that point in combination with immunotherapy.
Okay. And, give us a little maybe glimpse into the dosing schedule. What is your life like on these therapies?
So initially, with the regimen that I started with FOLFOX and immunotherapy, I was doing the treatment every 2 weeks. I would go on Wednesdays, and I would get a pump, right, that I had to take home, and have that onto Friday. I will go back to the hospital on Friday to get disconnected from this. I think it's 5-FU pump, and I did that for probably a year, and after that, it was one of the drugs in the FOLFOX regimen was dropped because it was giving me neuropathy, and at that point, I was given the option of whether I could continue with the pump, or I could do an oral medication for the equivalent of it. So I did the oral medication because, one, I hated the pump and I didn't want to be going to the hospital every 2 weeks. So at least with the pill, it gave me a sense of I don't know. I felt like the pump made me feel more like a patient, whereas the pill made me feel like, yeah, I was ill, but everybody takes pills, so I would just take these pills, and I've been on this pill for probably about a year now, and I've been doing this pill immunotherapy for about a year, and the scheduling changed also. It changed to only go there once a month. So I got infusion for immunotherapy once a month, and then the pill I take it at home. So I have a scheduling of 1 week on, 1 week off on it.
And how are your symptoms on these?
Initially, on the oral medication, I was having a lot of side effects. The original regimen was that I was taking this pill for 2 weeks on, 1 week off, and it was giving me what is known as hand-foot syndrome, where I would get blisters and on my feet, on my hands, and it got to the point that I couldn't really walk because it would hurt. Like I had these massive blisters on my feet. So, reducing the dosage and changing scheduling kind of control that to the point that now I'm able to walk fine and it's fairly manageable.
Okay, but you still have some of that.
From the immunotherapy, the main side effect that I've had with it is fatigue, a lot of fatigue, and I think it might be causing gastritis actually. Because I keep every time I get upper endoscopy, they tell me there's gastritis, that it could be induced by medication, but I don't know whether it's caused by the pill or the immunotherapy.
Okay. And the degree of the fatigue you have, do you still find it able to go do your activities of daily life? Like, how bad is the fatigue?
The fatigue kind of varies. The week that I'm on the medication is I wouldn't say severe, right? I'm still able to do things, and sometimes I just push through it. I did have to stop working. I used to do software development, and I had to stop working because one, the fatigue, like during the day, I would have to take a nap or something, and also the mental, the brain fog, right, that I would get from these medications. It would make me not be able to perform at work, so I had to stop doing that. And I think after I stopped working, it kind of helped, right? Because if I'm tired, I can take a nap and I don't can continue my day. Rather, before I would have to push through it, right, while I was working. And I think it kind of like cumulative. It made me feel tired all the time, if that makes sense.
No, it does. And thanks for detailing that. I know these are tough symptoms and you have to go through it every dosing schedule. But Sam, maybe, back to you, what are the different types of modalities, the different types of treatment options that one may potentially discuss with their doctor, depending on the stage in which they're diagnosed with a stomach cancer?
Yeah, big question. I'll try to answer at high level and happy to answer any specifics. So as you said, stage is very, very important. One of our main jobs as oncologists when we initially meet patients is to do our due diligence and make sure that we've checked all the boxes and that we have all the information to make the best guess at the stage of the cancer. Sometimes this includes something called a laparoscopy, where the surgeon will look around inside the belly to see if there's cancer cells hiding in places that are hard to see on CT scans, etc., what's called the peritoneum. But really, a big part of our initial job is the stage, because the stage helps decide what types of treatment are going to be in the toolbox. So, for example, if you're a stage 1, 2, or 3, the goal of our treatment is to cure you. And to cure you, sometimes that means we have to physically remove the tumor with surgery. Sometimes it means in people that can't have surgery, we'll think about radiation, although that's not very common in stomach cancer anymore. And then, of course, we have our medical therapies with chemotherapy and immune therapy and targeted therapies. For stage 4, of course, we're still trying to cure. We just recognize that in general, stage 4 cancers are not considered curable. They can be considered very treatable, and we have people like Frank and many others who are living a good quality of life, years after their diagnosis, and you would walk by on the street and have no idea what they're going through because they look well. I'll focus a little bit on maybe the advanced setting because that's most relevant to Frank. But in general, our goals are, kill as many tumor cells as possible, keep patients alive as long as possible, and do that in a way that maintains a quality of life that is acceptable to them. And everybody's definition of that is a little bit different. Some people might say, look, I'm not going to do any therapy that causes me any of this side effect. No hair loss, no X, Y, or Z. Those are perfectly reasonable things that we try to respect. But most people will require the initial tool to be chemotherapy, so combination chemotherapy, like Frank said, oftentimes 2 drugs, 5-FU and oxaliplatin, and Folfox is a very common combination of that. And then we bolt on top of chemotherapy based on the biomarkers. So, Frank said he was PD-L1, so they added immune therapy very appropriately. And that's exactly what the biomarkers are intended to do, help us decide what to add on. But broadly, our main tools for treatment are surgery, chemotherapy, targeted therapy, immune therapy, radiation, and then sometimes other small local therapies like things through the endoscopy. And I would certainly put at the top of all of these lists clinical trials. This is the way we make better therapies, is we test the new things in clinical trials because that's how we make it better. When I started doing this, there was no immune therapy to be combined with chemotherapy. There was no Claudin therapy to be combined with chemotherapy. They just didn't exist yet. And so only through clinical trials have we been able to bring these to patients and broadly approval. So I always encourage, patients at any stage of disease to ask the question, like, is a clinical trial appropriate or relevant for my case?
Yeah, I love that explanation. Thanks for offering all that. And I'm in this position where it's been so long since I've done any treatment for gastric cancer that I do not know what is exciting in the field there anymore. So, pitching back to you, Sam, is there anything that's in trials right now that you're particularly excited about? Something that individuals who are newly diagnosed may have as maybe a hope or an aspiration or something that they hold on to?
Yeah, for sure. I mean, I think I kind of think of them as different flavors. So there's trials that look to improve upon drugs that hit a target that already exists. So like HER2 is a good example. Classically, trastuzumab or Herceptin is the brand name, had been the drug. And over the years, we learned that we can combine that with immune therapy. So 2 different approaches. And I should add in the biomarker answer that patients can have more than one biomarker. You can be Claudin positive and PD-L1 positive, or HER2 positive and PD-L1 positive. And over the years, we've improved the drug. So we make better drugs against the same target. And over the past, let's call it 5 or 6 years, we have 2 other HER2 drugs. One is called trastuzumab deruxtecan, or TDXD. And then very, very soon, we're expected to see an approval for a new drug called zanidatamab, which is another cool way of targeting HER2. So basically, getting better at hitting the same target with better drugs is sort of one flavor of clinical trials. And so I'm very excited to see zanidatamab approval and available to us in our toolkit because it's a very active drug. Same thing for Claudin. We have zolbetuximab, which was the first drug approved based on some phase 3 trials. But Claudin is a target that can be hit many other ways. There's recently been a trial release in China suggesting that antibody-drug conjugates that hit Claudin improved the survival over chemotherapy. They've also done Claudin CAR-T, which is a specific type of immune therapy. And then there is some global Claudin ADC trials, one called Clarity-01, which we're eagerly awaiting the results because that may bring another tool against Claudin into our toolkit. And then there are types of trials that are totally new targets, and those are equally exciting. We have a whole bunch of new targets, CDH17, CEA, CCAM5, a whole host of other types of immune therapy approaches, bispecific antibodies, things called T-cell engager, where you try to force a T-cell right next to a tumor cell to do its killing. A lot of very interesting strategies in gastric cancer. being explored. And that's ultimately, that's great for patients. That's really what it comes down to, is more options is pretty much always a good thing.
But it's such an interesting time in the field because I think 15 years ago or so, there was this um, this expedition in each individual cancer to say what are the unique things about our cancer that we can precisely target, and then we had this feeling that, and it is true that every cancer is very very unique. And now we're in this area where we're finding more and more overlap again between the cancers using these new modalities, and HER2 is a great example. But many of the other things that you're excited about are also present on other tumor types. And the reason I think that's particularly exciting is because if you see advancement in one other tumor type that isn't the type of tumor that you or a loved one may have, that doesn't necessarily mean it won't make it over there. Progress in other areas is fueling progress kind of across the board. So I think that's a really exciting area, and particularly with the things that are targeting the proteins that are on the surface of the cancer cells now. Those we're finding are on the surface of many different types of cancer cells. Maybe not just gastric, but maybe breast cancer, maybe liver cancer, maybe lung cancer. So the research that's going into those different areas is benefiting a lot of different tumor types, a lot of different people. I think we're definitely in a rising tides raise all ships kind of area. I'm particularly interested in the CAR T work. That's what my laboratory works on. So I was very interested to see the CAR T that came out in gastric. Um, all these different types of modality, all these different types of treatments are coming out. It's an exciting field for us.
Yeah, we're copying lung cancer a bit now with this PD-1 VEGF bispecific approach, which has approval and positive phase 3 data in lung cancer, and now there's a few phase 3 trials in gastric cancer to see if we can enhance the effectiveness of immune therapy, essentially.
Yeah, it's an amazing time for research. And Frank, as we're talking about the reasons why we're optimistic in the field, does that permeate to the patients, you think? Do you feel that in your side, in your seat, that the advancements that are happening in the research lead to more hope for the patient?
Yeah, I would say so. I mean, I went to ASCO this year actually to look at the at presentations and research that was presented then, and it's encouraging, right? It gives me hope, and it gives other patients that I talk to hope, knowing that there's a lot of people and there's a lot of stuff going on at the same time, right? So because a lot of people are afraid that maybe chemotherapy is the only option that they have, right? So seeing that it's an active field is encouraging and gives us hope.
Yeah, I mean that's great to hear. I'm curious, what did you think of ASCO? It's quite the ordeal, huh?
Yeah, I thought it was interesting, but it was a bit overwhelming at sometimes, right? It was huge.
It's overwhelming for me, and I have an itinerary, and I know what I'm doing. I can't imagine being the patient trying to figure out like what are the things here that are going to benefit me. How do I keep my finger on the pulse? And then you walk into this massive conference center with like 50,000 people. Um, were you able to find the
Yeah.
data and the information you were hoping to find?
Yeah, I think I did, and plus I was there as a patient advocate to talk to other patient advocates to see, how they advocate for their different type of cancers, and so it was both, networking and also learning about new research that was presented.
Yeah, I think this is maybe a good segue now into talking about, we've had a bit of an overview of generally kind of how we look at staging, and then for individuals who are going to be on treatment that goes throughout the body, a couple of different flavors of what that treatment may be. I'm curious, Frank, how do you disseminate that information to the patient organizations, and how do patients hear about trials they may be interested in, advocacy organizations, those kinds of things?
I think initially for me, and probably still now, is support groups have been a huge thing for me. One of the ones that I'm mostly involved with, Hope for Stomach Cancer, they do two summits, one in DC and one in LA, where they, both bring some, either surgeons or oncologists to present different research or explain things like Sam is doing. And also there's a lot of support from other patients, right? Kind of like supporting each other. And I think that helps kind of like make things easier to understand, to hear from another patient themselves.
Sure. And, along those lines, you're now in a role where you're helping individuals who are newly diagnosed. When you were first diagnosed and you were told that this is a stage 4 gastric cancer, what was going through your mind?
I'm not sure. Actually, at the time, I was a lot of panic. So I don't know what I was thinking, to be honest. Um, and eventually, kind of like the panic comes down a little bit, right? I guess I couldn't be in a state of panic for forever. And being more involved with the support groups and being more involved in trying to help other patients kind of, in a way, helps me, right? It helps and gives me myself some hope as I'm trying to encourage other patients or maybe calm them down a bit.
And what pieces of advice do you give when people need hope? Like, how do you provide that?
So the main thing that I think I'm almost like a broken record at this point is to tell patients about the second opinion, right? Because I went through this misdiagnosis for months, and I just don't want another patient to kind of go through that, right? Especially when it's kind of hard to diagnose, and time is kind of of the essence when it comes to, like, say that you're a stage 4 patient, right? And some of the gastric cancers can be very aggressive. So I push a lot for one, getting second opinions, and also to look into clinical trials. I haven't been on a clinical trial yet, but I keep my eyes open to hopefully be able to get into one. To one, gives me some time to maybe save any of my, standard lines of treatment for later on, right, while I'm on a clinical trial. So those are the main things that I typically try to talk to patients about.
Frank, do you ever hear from other patients that you're talking to an apprehension or a concern about seeking a second opinion because they don't want to upset their oncologist?
Yeah, it's actually quite common for them to feel like they usually tell me, right, like, oh, I trust, my oncologist wholeheartedly. And I tell them that it's not a matter of trust. I mean, I didn't seek a second opinion because I lacked trust on my oncologist, right? Like I said, I was just trying to get treatment faster, and I feel like there's really not much to lose, right? By seeking a second opinion. I tell them that maybe you hear the same thing that you already heard, or maybe you hear something better, right? But yeah, it is a common apprehension from patients that they feel like they're going to upset their team, or their oncologist or whoever's treating them. But I feel like maybe as an oncologist yourself, maybe you can talk more about this. I don't see how it will be insulting for them, right, for somebody to seek a second opinion.
Yeah. No, I think most oncologists want the best for their patients. That is like a pretty unifying thing. And so in a cancer that is not super common, like stomach cancer, where, I see it all day, every day, because that's what I do. But people who work in Maine, an hour north of me, might see 4 stomach cancers in half a year. And so it's just a fact, it's hard to stay up to date with everything if you don't live in it. Just like you can't stay up to date with, all aspects of any job. And so it makes sense for those people to see the expert. If I had some super rare custom car, I would take it to a garage that had experience with that custom cars. Just like someone who has an uncommon cancer should go to someone who has expertise in that uncommon cancer, if at all possible. even if it's just to say, hey, yeah, the person taking care of you is doing a fantastic job. I would do the exact same thing. We're happy to see you in the future, but feel free to continue with your team. I'd say half the time that's what we say, because most oncologists are making sure that they're doing the best thing for their patient. Sometimes we have something we can add, which is often in the research side, because research is generally concentrated at larger cancer centers. But no, I would encourage, not just stomach cancer, but most cancer patients to consider if a second opinion would help give them peace of mind. Even if it's just knowing that you talked to another person and heard another point of view, or sometimes it just clicks when someone different explains the same thing to you. They explain it a different way. Sometimes it's just your personalities mesh a little better, whatever it is. I don't know too many oncologists who've been bothered by their patients getting additional opinions. In fact, we either encourage it, and we're often, helping to facilitate it. Like in Boston, we have several really good cancer centers. So half of our patients, or maybe a third of our patients, go see, one or two of the other centers. And that's fine. I don't blame them for that. But I do recognize that there are people who feel like they're going to be offending the expertise of their medical team. And it will take time to change that culture, that perception. I do think that it is changing. And most oncologists will not be bothered by that.
Yeah, I think this is a theme we've seen over and over again in the podcast, where second opinions are critical, particularly when things are rare. And many times things are rare. Maybe it's rare that you have a certain biomarker. Maybe your primary diagnosis of what kind of cancer you have is rare. But getting, the peace of mind, or what trials are available, maybe different at a given institution, and you just kind of want to shop around and see what your options are. Most of the time, I'm hearing apprehension more from patients not wanting to upset us. And it's interesting because, we're not the ones who would actually have to live with the consequences of our recommendations. It's the patient that has to live with what ends up happening. So the patients don't owe us anything. We're here to help guide your ship that you're sailing, but you're the captain there. So it's nice to hear the push for second opinions. And I had no doubt of saying what your response there would be. Nowadays, I think we're all pretty open, and if someone comes and gives you a recommendation that is different from what you said, maybe you have a chance to learn something, and that's always kind of reassuring if they found something that you didn't know about. It's nice to be able to offer your patient that. So usually we strongly welcome that, probably across all cancers, including gastric, it sounds. And then Frank, as we kind of close out here, I'm wondering if you had a piece of advice for someone else who's newly diagnosed right now, who's struggling with this diagnosis, who's scared. What advice would you give them?
I think the main thing that I want to say to a newly diagnosed person is that there is hope. I mean, there's like Dr. Klempner was mentioning, there's new research, there's new treatment options coming up in the pipeline, right? And I think you can live a fairly normal life. I mean, I feel like I live a fairly normal life, right? I've been with this for 2 years, and over 2 years now. And, I was diagnosed at stage 4, right? So if somebody's diagnosed at earlier stages, maybe their life won't change that much, right, from what they're used to. So I feel like there's some hope in the horizon.
Well, thanks for echoing that. And Sam, any advice that you would give for someone who's newly diagnosed with gastric cancer?
Yeah, I think, like they say, age is just a number, and there's 80-year-olds doing backflips. Like stage is also just a number. Like, it is important, but it's a huge mixed bag among stage 4. There's sort of a lot of variations on that. So I think the message is hope. The advice is, try to get information. Don't hesitate to ask questions. If you don't ask, you don't know. The person who is the most invested is the patient. It's their life. And so you should educate yourself as best you can and try to seek out information, connect to other people, experts, other patients, etc. There's a lot of information accessible, some of it good, some of it not as good, but it's out there. And so, look around, ask questions, and understand that, there's a lot of stuff we can actually do. It's not okay, gather your things together and prepare for the end. It's, you got to deal with this problem, but, we can actually deal with this problem.
Well, thank you both for offering the inspiration there and ending on a positive note, which I think is very genuine. I don't think we're making up the hope that's coming out these days, particularly Frank, for what you were seeing at ASCO, and Sam, the trials you're running. So thank you both for joining us today. We'll cut it there, but folks, if you have other questions online, you can submit it at crackingcancer.org, and we'll see you next time. Bye, everyone.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.